Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. We're
Mhm.
really diving deep today into the general treatment strategies for breast cancer,
Okay.
specifically focusing on, I guess, the multidisciplinary approach
Mm.
and the role of surgery. I think it's really interesting because like a lot of the topics we cover,
Yeah.
it's really fascinating how much it's evolved,
Right.
even in the past couple of decades.
Yeah, for sure.
You know, we've got so much to unpack about how we decide the sequence of treatments.
Hmm.
When and why might we choose surgery first versus starting with neoadjuvant systemic therapy?
Absolutely. And I think you hit the nail on the head when you said how much things have evolved. I mean, what we considered, even a couple of decades ago, a primarily surgical disease
Right.
is now this really integrated dance between different specialties. It's not just about getting the tumor out anymore.
Yeah.
It's about, this sort of carefully orchestrated sequence of therapies
Yeah.
tailored to each individual patient and their unique tumor biology. So this collaborative approach, this multidisciplinary team, or MDT,
Yeah.
that's really, I think, the cornerstone of modern breast cancer care.
The MDT, yeah, it sounds so straightforward when you say MDT.
Right.
But, I mean, really, there are so many players involved.
Oh, absolutely.
Can you kind of walk us through,
Sure.
like, who's typically involved and why it's so critical, for this team-based approach
Yeah.
to be so vital for our patients?
Yeah. So, I mean, at the heart of it, you have the surgical team.
Right.
Right. But that's just the very beginning. We rely so heavily on our radiology colleagues
Absolutely.
for that initial diagnosis, for staging the patient with imaging,
Yep.
and then for monitoring their response.
Uh-huh.
And then, of course, we have the pathologists who are absolutely vital.
Yeah.
Their detailed analysis of the tissue, the histology. It gives us so much critical information
Yeah.
about the tumor characteristics,
Yeah.
how aggressive it might behave, and what therapies it's likely to respond to. And then you've got the radiation oncologists.
Of course, who are crucial for obtaining local control in many scenarios. And then the medical oncologists,
Right.
who are real critical in guiding the systemic therapies,
Yeah.
the chemotherapy, the hormone therapy, the targeted agents. And of course, we can't forget the plastic surgeons
Yeah.
who played, an increasingly important role in reconstructive options.
Yeah.
And that really impacts patient quality of life significantly.
It's a broad, it's a broad church, isn't it?
It is.
Really. I mean, and it extends even beyond just those who are directly treating the tumor.
Absolutely. I mean, the allied health professionals are indispensable to this whole process.
Yeah.
Our breast care nurses, they're the linchpins, right?
Yeah.
They provide invaluable support. Patient education, continuity of care
Yeah.
for patients that are navigating, what can be quite a complex journey.
Totally.
And then we also have the psychological counselors who address, the significant emotional and mental health aspects of a cancer diagnosis.
Of course.
Right.
Of course. And then with our growing understanding of genetics, genetic counselors are really key in identifying any hereditary risks.
Yep.
And framing treatment decisions for the patient, but also potentially for their families as well. So it's really, this truly collaborative effort
Yeah.
that makes sure we're addressing all these facets of the patient's well-being.
Yeah, and it's interesting. I've read a lot about, I think some studies have shown that hospitals with strong MDT integration,
Right.
they often see improved survival rates.
Yeah.
So it's clearly,
different.
it's not just about,
Lip service.
yeah, exactly. So let's talk a little bit about the initial treatment strategies.
Okay.
So it seems we generally have two main paths we consider: surgery first
Mm-hmm.
or neoadjuvant systemic therapy.
Right.
When would we typically go towards starting with surgery?
So I think surgery as a primary treatment is
Yeah.
generally our go-to for patients who present with what appears to be a lower burden of disease. So we're talking about smaller tumors, perhaps without palpable lymph node involvement. And based on their initial imaging and biopsy, tumors that don't seem to exhibit highly aggressive biological characteristics.
Okay.
So the thought process there is that we can achieve good local control with surgery, obtain that definitive pathology,
Mm-hmm.
and then tailor the adjuvant therapies,
Right.
like the chemotherapy, the hormone therapy, or the targeted therapy
Yeah.
based on that final risk assessment. So it's kind of that more traditional approach
Right.
for what seems like early stage localized disease.
Right. So address the local issue immediately
Exactly.
when it appears to be contained.
Exactly.
Now let's consider the flip side: neoadjuvant systemic therapy, or NAST,
Right.
where we're giving systemic treatment before we even think about the operating room.
Okay.
What's the rationale behind that?
So the primary goals of NAS are really two-pronged. First, it's about tumor downsizing.
Uh-huh.
So a tumor that might initially be too large for breast-conserving surgery, let's say like a T3 or a T4 tumor, it might shrink significantly with systemic therapy.
Right.
And that could make lumpectomy a possibility instead of mastectomy.
Wow.
In some cases of locally advanced disease, it can even render a previously inoperable tumor resectable.
Oh, wow.
But perhaps even more importantly, NAST allows us to assess the tumor's response to the systemic therapy
Right.
in vivo. So that's within the living organism.
Yeah.
And that gives us invaluable information about the tumor's biology, its sensitivity to different drugs, and it can really help us in deciding on the most effective post-operative adjuvant treatment.
Right.
So it's a way to really personalize that entire treatment journey much earlier on.
And NAST isn't one size fits all, is it?
No.
We've got different types depending on the tumor's characteristics.
Exactly. So under the umbrella of NAST, we have neoadjuvant chemotherapy. So that's NECT. We have targeted therapy. And we have hormonal therapy. And our choice really hinges on the specific subtype of breast cancer.
Okay.
So the estrogen and progesterone receptor status, the HER2/neu status, and the tumor grade.
Okay.
All of which we get from that initial biopsy.
So let's dive a little deeper into neoadjuvant chemotherapy,
Okay.
or NACT. When in your experience are you most likely to reach for chemotherapy as the first line of attack?
So NACT is often a very clear choice in locally advanced breast cancer.
Okay.
So that's when we see a tumor that is larger than 5 centimeters. So that's a T3.
Okay.
Or one that has extended to the chest wall or skin. So that's a T4.
Uh-huh.
Or if there's involvement of 2 or more regional lymph nodes, that's an N2.
Okay.
Or matted or fixed nodes, that's an N3.
Okay.
And in these situations, our primary aim is to achieve significant tumor shrinkage, just to make surgical resection even feasible.
Okay.
But we also consider it in certain cases of early breast cancer. For instance, if a patient has a tumor that's borderline, for breast conservation, let's say it's around 3 to 4 centimeters. NECT might downstage it enough to allow for a lumpectomy.
Oh, wow.
Rather than a mastectomy.
That's amazing.
We're also seeing it used more frequently to study the chemosensitivity of individual tumors.
Okay.
Which in some cases can actually inform adjuvant therapy decisions more effectively than a surgery-first approach.
Got it. Are there specific molecular subtypes where NESCT seems to offer a particularly strong benefit, even in early-stage disease?
Yes, absolutely. So HER2 positive breast cancer and triple-negative breast cancer, so TNBC, they often show good responses to chemotherapy, and NICT allows us to really observe that response directly.
Yeah.
We also tend to lean towards NACT more frequently in premenopausal women.
Okay.
So those under the age of 50.
Okay.
And patients who present with axillary lymph node metastasis. So the presence of nodal involvement often suggests a higher likelihood of systemic disease, making upfront systemic therapy a logical step.
Yeah. Now, what about neoadjuvant targeted therapy?
Okay.
When does that become our primary systemic approach before surgery?
So neoadjuvant targeted therapy is really focused on HER2 positive tumors that are larger than 5 millimeters. Our standard of care often involves agents like trastuzumab and pertuzumab, and they're frequently given in combination with chemotherapy. The goal here is to really specifically target the overexpressed HER2/neu protein on the cancer cells, and that can lead to significant tumor regression in a good number of cases.
And hormonal therapy in the neoadjuvant setting. I mean, that feels like a different scenario altogether.
It is. It is. So neoadjuvant hormonal therapy is typically reserved for, older or more frail women with ER and or PR positive advanced tumors who might not be suitable candidates for chemotherapy, because of other health issues. So
of course.
It's a less aggressive approach. And it's important to remember that the response time with hormonal therapy is generally slower than with chemotherapy. We often need to wait 3 to 6 months before seeing clear clinical evidence of effectiveness.
Got it. So we've initiated neoadjuvant therapy. How do we actually gauge if it's working? And at what point do we decide to proceed with surgery?
So we monitor the response to neoadjuvant therapy through regular clinical examinations and imaging studies. like mammograms, ultrasounds, and MRIs. A standard evaluation is typically performed around 3 weeks.
Okay.
After the second cycle of neoadjuvant chemotherapy.
Okay.
And we use the RECIST criteria.
Okay.
That's the response evaluation criteria in solid tumors to try to objectively assess the response based on changes in tumor size.
Okay.
It's not a perfect system,
but
it gives us a standardized way to evaluate.
Can you kind of briefly outline the RECIST criteria for us?
Sure. So a complete response, or a CR, means that we can no longer detect the lesion on physical examination or imaging.
Wow.
A partial response, or a PR, is defined as at least a 30% reduction in the longest diameter of the target lesion. Stable disease, or SD, means that there hasn't been enough change to qualify as a PR or progressive disease. And then progressive disease, or PD, indicates at least a 20% increase in the longest diameter of the target lesion.
Got it. So think of it as like measuring the tumor size at different time points. And seeing how it changes.
Exactly.
So how do these response assessments guide our surgical decision-making?
So if a patient achieves a complete or partial response, we generally continue with the planned chemotherapy regimen before proceeding with surgery. For those who were initially candidates for breast conservation,
it becomes really critical at this stage to place a radio-opaque marker at the original tumor bed. So this could be something like a mag seed or a small titanium clip. And this essentially acts as a breadcrumb for us in the operating room, helping us precisely locate that area for excision. Because that tumor might not be palpable anymore if we don't mark it. It can be like trying to find a needle in a haystack.
Absolutely. That's a vital step.
It is.
For ensuring accurate resection after a good response.
Right.
Now, what about patients who don't respond as well? Those with stable or progressive disease during neoadjuvant therapy.
So in those cases of stable or progressive disease, our typical approach is to proceed with surgery. Because continuing a treatment that's not showing efficacy isn't usually beneficial. After surgery, based on the final pathology.
We would consider switching to a different second-line chemotherapy regimen in the post-operative setting or in the adjuvant setting. But the information we gain from that lack of response to the initial therapy is still really valuable in guiding future treatment.
So regardless of whether we start with surgery or neoadjuvant therapy. Surgery remains, I mean, it's a cornerstone of breast cancer management.
Absolutely. While the sequencing of treatment has become a lot more sophisticated, surgery for local control remains a critical component. And we've seen, a significant and appropriate trend towards de-escalation of surgery with more judicious use of breast conservation surgery when it's oncologically safe and offers good cosmetic outcomes.
And the data really overwhelmingly supports that.
It does.
That shift towards breast conservation in appropriate cases.
It does. The evidence is very robust. Numerous large clinical trials and meta-analyses have clearly demonstrated that in well-selected patients, breast conservation surgery followed by radiotherapy provides equivalent local recurrence rates and overall survival compared to mastectomy.
It's about achieving the same oncological outcome. With a less extensive surgical procedure. So what are the fundamental objectives we're aiming for during the surgical procedure itself?
So the primary goal is always the complete removal of all disease in the breast and the axilla if involved. And this means achieving negative surgical margins. So ensuring that when the pathologist examines the removed tissue, there are no cancer cells present at the very edges or margins of the specimen.
And that brings us to the absolutely crucial role of our pathology colleagues. Once the surgical specimen is in their hands.
So the pathologist meticulously examines that specimen. Analyzing the tumor size, the grade, the lymph node involvement, and critically the distance between the tumor and the nearest cut edge or the excision margin. And to help them with this, we routinely apply indelible India ink to the surface of the specimen in the operating room. And this ink essentially marks the surgical boundaries.
That makes sense. And what are the generally accepted guidelines for those margins? What defines a negative margin in practical terms?
So for invasive breast cancer, the current standard is no ink on tumor.
Okay.
That means that there should be absolutely no invasive cancer cells touching that inked margin for DCIS because it's a non-invasive lesion.
Right.
We typically aim for a minimum margin of 2 millimeters to really feel confident about adequate local control.
Right.
And these margin guidelines are really critical for minimizing the risk of local recurrence.
Yeah, I mean, it's a truly intricate process, this whole sequence of treatment.
It really is.
From the initial diagnosis, the collaborative planning within the MDT.
Right.
Through, the nuanced decisions about neoadjuvant therapy, right up to the surgical resection and the meticulous pathological assessment of the margins.
It is. Each step is so interconnected.
Yeah.
And it relies heavily on clear communication, shared expertise, collaborative decision-making within that multidisciplinary team.
For sure.
It's this integrated approach that allows us to really optimize outcomes and provide the best possible care for our patients. I mean, the way we can personalize treatment now based on tumor biology and response is it's a testament to how far the field has come.
We've navigated the complexities of initial breast cancer treatment.
We have.
From the collaborative MDT approach to the critical decision points in surgical management.
Right.
Following neoadjuvant therapies. Understanding these strategies and response assessments is paramount in providing the best possible care for our patients.
Indeed. The integration of systemic therapies with surgery has fundamentally changed how we approach breast cancer, allowing for more tailored and effective treatments. And, the ongoing research continues to refine these strategies. And it's an exciting time to be in the field.
It is. It is. Well, thank you for listening to our podcast. See you in the next episode.